Thanks very much for coming along on this Wednesday evening. And yep, so this section is on Advanced Life Support 2022. What your patient having a cardiac arrest really wants you to know. And that's pretty much, these two things, how to keep them alive, and then repeat step number one. So what do you need to know to get there is pretty much these things. What is a cardiac arrest? Because that really helps in everything that you're going to do after that. The 5 phases of advanced life support. And then what are the evidence-based things that can really help you get there and what matters most? So here's one of those interesting questions that I don't know if you've ever been asked this in med school, but why are you alive right now? And it's just this beautiful process of the fact that there's oxygen out in the atmosphere. It somehow gets in through your airway down into your lungs, and then it attaches to red blood cells by crossing across that membrane in the pulmonary capillary. And then the heart pumps it around to various organs, including the most important ones for survival: brain, heart itself, kidneys, and other tissues. And that's all via the arterial system. And then it gives oxygen to these tissues. Oxygen molecule enters the cell, allows ATP production to keep the cell alive. And yeah, if you just imagine the body, you can imagine that this is constantly happening: air going in and out, blood going round and round, and tissues having metabolism that allows them to generate ATP and just do everything they need to do. So what is a cardiac arrest? Now, this is obviously a really important question. So it's when that oxygen molecule is unable to get to the cardiac and tissue cells, and then you get some kind of cardiac arrest. And that could be everything from your heart muscle having a funny rhythm, ventricular fibrillation or ventricular tachycardia, or the heart could be pumping, but ineffectively because there might be no volume or something else might be going wrong with the actual circulation. So cardiac arrest is either the heart or the circulation, and causing those problems is why you get badness. So the cardiovascular system is unable to perfuse vital organs, and that's when this happens, and is either due to these shockable rhythms, VF or VT, or non-shockable rhythms, which is pretty much any other rhythm that could be perfusing. Now, interestingly, I always thought of shockable rhythms as just shockable rhythms and non-shockable rhythms as due to reversible causes. But it's interesting that really the reversible causes are just some really common high-end pathologies that could cause either shockable or non-shockable rhythms. Now, interestingly, there's the fortunate, but I guess unfortunate thing, there's only a few things that have really good evidence of cardiac arrest. And the Advanced Life Support Manual and the ARC talks about this chain of survival, and this is directly from them. If you have early recognition, that's kind of obvious. You've got to discover that there is an actual cardiac arrest going on, and then you'll be able to treat it. Early chest compression CPR, that buys you time. It keeps the heart pumping. Early defibrillation restarts the heart if it's in ventricular fibrillation or VT or a bad rhythm. And then once you've got them back, you need to just have really good quality post-operative care. So the purpose of the ALS guideline is to make all of this happen, really. So it's all really completely logical to me now. If you have early recognition, you can sort stuff out. If you give early chest compressions, the heart that's stopped, you just keep pumping on that chest. And essentially you're trying to be the heart muscle itself. And then if there's early defibrillation, you can restart the heart. Effective post-resusc care means that you keep the patient alive and do all these other things to keep them alive while you're finding a definitive solution, which we'll go to in a second as well. So let's make sense of these guidelines. So first of all, has everyone seen the basic life support guideline and the advanced life support guideline? These are obviously really, really important and very busy guidelines. And I want to try and, in this talk, just make really good sense of that. So these guidelines, the way I think about it is actually not the way that it's written out. There's 5 phases. So the phase 1 is identifying the arrest. Phase 2 is CPR cycles. Phase 3 is safe defibrillation. 4 is reversible causes. And 5, okay, phase 1, identification of the arrest. Now you enter a ward and see a patient collapse unconscious in front of you. So what is your framework there? Now, this is really quite straightforward because it really is that sick versus well framework. So, if the patient is sick, we go straight to doctors A, B, C, D, E. But if the patient is well, that's when you can do your history, examination, investigation framework. So phase 1 is really to rapidly identify that arrested patient. So this BLSD doctor's ABCDE flowchart really just gets you to that solution, okay? So this whole flowchart is really just to do a few things. I get there, my actions are check for danger, modify the environment. And these days you've got to say something about putting on PPE as well as actually doing it, because it's, it's such a real thing. I mean, first of all, you get COVID. Next thing you know, there's monkeypox. Who knows what the next thing that's going to be out there, right? Check for response to voice or pain. And this is something that's really important. Often I remember getting asked to see patients who are unconscious, and all I did was go up to the patient and really shout and give them a really good nail bed pressure or trapezius squeeze. And the patient was always able to respond. So just remember that every time you call for an unresponsive patient, if you shout with a really loud voice, that will make all the difference. And firm trapezius squeeze. You want to absolutely be sure that this patient is not simply over-narcotized or at whatever pathology has caused them to be unresponsive to a certain level. Send for help, whether it's emergency buzzer, nurse, 000, whatever it is. Obviously, you need more hands and more brains. And then you do this. Look and listen for obstruction, and you relieve it with your maneuvers, adjuncts, and whatever else you can. Look, listen, feel for normal breathing. You'd have heard of this all before. Now, if the patient is lifeless with an open airway and no breathing, what do you do next?
Yep, so the patient's not responding, so lifeless, open airway, so that's telling me patent, there's no obstruction, and they're not breathing. That's when I commence my CPR, effectively.
Yeah, fantastic. Exactly. You go straight to CPR. Now, why is it that we don't tell you to check for a pulse? At some point here, this patient has not enough heart output, whatever it is, to get them to perfuse their respiratory centers and get them breathing. Now, what happens if this patient was just overly narcotized? Isn't it true that they still could have a very good perfusing rhythm, and checking the pulse could be a worthwhile thing to do?
Just from what I know, it's still worth it, or rather, it's still more important to just get the early CPR going without checking. That's the most important thing, and you can worry about the pulse later. Like if you give them CPR and they have a pulse, so it's still better to give them CPR.
Yeah, exactly. And let's say they were narcotized, chest compressions will definitely wake them up, and that will be almost diagnostic for whatever level of decreased conscious state they had. And yeah, there's very little harm of chest compressions. And I've got to say as well, when you see enough, this sounds a bit morbid, if you see enough dead people, you'll realize what dead looks like. I mean, the times I've seen it, I've just gone in and gone, I don't even need to check anything. This is a lifeless patient. They look gray, they look lifeless. They're just so still, it's creepy. So that's why it's very difficult to make this mistake of giving chest compressions to a patient who is alive. You will know when you see someone who's dead. And then finally, this chart also goes into attaching the AED. So look at that whole thing. That whole document is really just to tell you this patient is now arrested, and we're going to start doing the actions that are most evidence-based. So the aims: identify the arrested patient, get expert help, and then institute the only things that are actually evidence-based: chest compressions, defib, and obviously the early recognition. So think about that. If all you did was BLS, that's pretty much all you need to keep the patient alive. It's almost insulting that they call it basic life support, because everything else is advanced, but everything that's evidence-based is in there. The fact that you do advanced is just to get expert help and do a few other fancy things that might reverse things around it. But all you need is BLS at the start, at least. So now you're doing phase one, which is the BLS flowchart, and you're keeping the patient alive while waiting for expert help to start with the next phase. So we've asked, why don't we feel for a pulse? Like literally, when they've done feeling the pulse, whether you're an expert or an amateur at this, people are bad at feeling a pulse. Often, especially really low pulses, you start feeling your own pulse. And if you've ever done that, you go, oh, I mean, it seems okay. And you can second guess yourself. So it's a really good thing just to don't worry about feeling a pulse, but also get into the practice. If you are going to feel for a pulse, just take 5 seconds and practice on yourself, practice on the wrist, on the brachial artery, on your carotid. Just get really used to feeling for a pulse, because when it matters, it's really important. Like one of the things I do as an anesthetist, when I'm there with the patient, I'll just kind of, just for practice, feel the pulse of the neck or feel the pulse of the wrist, just to know that I can do that quickly. So still I don't want to say don't become an expert at feeling for pulses, but definitely don't need to feel for a pulse because it'll waste time. And also the question of how long can you do this for? Like how long can you do phase one BLS chest compressions for? I mean, the answer is it's a complicated answer, but in a young patient who you don't expect to have any problems, you really just want to keep doing it until expert help arrives. Do not stop chest compressions unless you're kind of senior enough and have enough collaborators to make a tough decision, I'd say. You may be in a very remote context and help may not be there for a while. If you can do some level of chest compression to keep them alive until help arrives, that would be a good thing. Okay, so that's phase one. Okay, phase two is CPR cycles, right? So really the question is, how do you make all of this happen? Now, I think this is a really great flow chart. The only problem with the flow chart, when I first started looking at this, it didn't actually tell me what I needed to do in a very crisis management setting. So that's what I want to go through with phase two. So my actions are literally to identify that there's 4 critical tasks with advanced life support. And I've got to make these things happen if I'm the leader. Or if I'm not the leader, I've got to make sure that I'm checking that I am doing one of these if there's only a few helpers around. So the first one is chest compressions. And I put that first because all you need for chest compressions is your hand. You just need to be there, jumping on the chest and trying to keep the patient alive. The second one is defib, but the next few could be in any order, really. So defibrillation obviously is very important because it's, again, the next best evidence-based method. Airway management, usually that takes, again, the crash cart to come over and the bag mask to be there. So that's why I've just put it afterwards. And finally, IV access, adrenaline, and other drugs. So these, essentially, as soon as people arrive, if they're taking ownership of this, these are the 4 things that I'll dictate that people need to do straight away. Chest compressions, defib, airway management, IV access, and adrenaline. So just imagine in a situation, especially if you're being examined as well, it's really impressive for you to say, these are my 4 priorities once help arrives, and then move on and elaborate on each of these points. So my aims, again, I initiate the vital roles. I rapidly institute the evidence-based things, which is chest compressions and defib, and then I start the advanced medications. How many people do you need to run an arrest?
This has put me on the spot.
Absolutely. It's a bit of a trick question. So
yeah. Maybe to run an arrest, maybe just 1, but to do the full thing, maybe more. Yeah.
Your gut feeling is right. Literally, if all you have is you and your 2 hands, and let's say you've broken an arm and all you have is 1 hand, and let's say you've broken both arms and all you have is your foot to jump on the chest, it doesn't matter. You can still keep someone alive to a certain level. Now, when I started running sim, I never really thought about this because you always have too many people in an arrest, especially in a big tertiary quaternary hospital. But I just stepped this out. So take a screenshot of this if you guys want. But this is roughly how many people you need. So chest compressions, you at least need 2 to keep swapping over. It'd be great to have 1 person on defibrillation because that's the whole thing you need to manage from a safety point of view. You need at least 1 person, for airway management. But often you'll have another kind of second pair of hands helping you for the intubation or getting the LMA. Often it's going to be one of the nurse or the technicians, maybe even another doctor. Then you'll have someone getting IV access and maybe putting in other lines, getting some drugs ready. That could be 1 to 2 people, depending on how quickly you're doing it. You definitely need a team leader at this point. Once a lot of people start coming in, having a separate team leader who's at the end of the bed, just looking at the overall situation, absolutely vital. Then you need the scribe. The scribe, I'm going to be talking kind of quickly about all these points, but I'll tell you a bit about the organization, right? So you've got the person at the airway, that's at the head, obvious position. You have the defib on one side, and you make sure the chest compressors are changing on the other side so they don't get in the way of the defib. The next thing you have is, people at the foot of the bed. That will be the leader standing, watching the arrest and observing everything from a bit of a distance. And next to them will be the scribe, because the leader wants to coordinate with the scribe all the timings constantly. So that's kind of how the room will be arranged, if you can imagine that. And I think I should probably put a picture in next time. And finally, you'll always have extra hands. Now, the one thing it'll be hard to do as a junior, especially as a medical student or junior doctor, but as soon as you get in, there'll be too many people. So what I often do is, as soon as help arrives in theater, I get 1 person, I tell people how many people I need. I need 1 anesthetist, 2 nurses, and I need 1 person there just to be crowd control. So you'll observe this, it's a real thing. And I might as well tell you guys now because it's something that people talk about a lot these days, having crowd control, keeping the noise down, getting rid of any unnecessary people. That said, when I have a med student or one of you guys with me, and I hear a code blue, I really want you to go to it and just observe from the window, just like peeking in, just to see what they do well and what they don't do well and how they can improve. So that's 9 people, let's say. Ideally for an arrest, depending on many other circumstances with lots of disclaimers, about 9 people I reckon is pretty good. Let's go into the detail of this. Now, what does good chest compressions mean? So now, when you go into the resus.org.au website, so that's www.resus.org.au, you can go to the guidelines tab. And in the guidelines tab, if you want to get into some real detail, those guidelines that you can open up, just really good PDF files, are evidence-based, have lots of information, and that's where I get all my knowledge. So the flow charts give you a little bit of knowledge at the surface level. If you want to be real, smart asses with this kind of topic, read those guidelines and make some summaries out of them. This is roughly the summary of it. So where do you do good chest compressions? The lower half of the sternum. Just look at roughly where you think the heart might be. The depth is at least 5 centimeters, but literally I'm just going for I go until I get resistance. The rate is 120 per minute. And generally speaking, people seem to go faster than that. So it's really good to be able to time it. Often we talk about the song Staying Alive being about the timing. So staying alive. You minimize interruptions and switch providers every 2 minutes. Now, there's a lot of other things that you can read about this. For example, you might read about the duty cycle, which is you want 50% down, 50% up. So you don't want it to be like a slow down and then a sharp up. You want it to be an even thing like that. You want complete recoil without your hands going off the chest, because that just keeps you in contact and keeps the heart filling as much as it can. If you're compressing to the full AP diameter of the chest, that's great. If you just do this, the heart's not going to be getting enough diastolic filling with the release of what you do. You definitely want a hard surface as well. And they've done studies on various things about, the fact that you lose a lot of energy if you have a soft surface. So if they're on one of those really soft beds that often patients are on, somehow getting a flat board under it or deflating the bed might be the best thing. So they've got a hard surface. What I've found is that 2 minutes is longer than I can really give my best as well. So I would say when I'm running an arrest, as soon as I see someone tiring, it's probably in 30 seconds to a minute, I just get the next person to swap over straight away. And hopefully you'll see that happening in good arrest as well. Now, this is just a really good summary of what happens. Imagine you've got really good chest compressions going, and when I've had an art line in, you can get 100, 120 systolic pressure. What's interesting is the diastolic pressure is also very low. So you can get some really good systolic pressures with good chest compressions. It takes a while to get the momentum going for the blood and that stagnant circulation. But once you stop, everything declines. The inertia of the blood is so much that there's just no perfusion. And once compression resumes, it takes about 10 seconds to rebuild that momentum. And so this is a pretty good actual graph of what occurs, where you get a rise in the arterial pressure, and then then it falls. And then as you do the compressions again, you see that the pressures rise and the flow progresses as well. So what do you do for effective airway management? And again, expert help is probably the best thing, but any one of you with a couple of sessions in anesthetics or with airway can be really good at this. And what I'd suggest is you get that bag mask on in any case, and you optimize the way you'd optimize in the worst case scenario. So what that means, in the worst case scenario, when all I've got is the skills of bag masking, I would add in high flow oxygen, 15 liters. I mean, those flow meters, they say 15, but if you keep going, you get more than 15. So I just keep turning it. You chuck in a Goodell, make sure it's sitting well. You get 2 hands on there, and then you get an assistant to also help you with ventilating. Also, I mentioned jaw thrust as well. So imagine that. Bag mask on, high flows, Goodell in, 2 hands in a jaw thrust, holding the mask for dear life, lifting that face up towards the mask, not compressing down. And then you continuously evaluate. So this is the one thing that I'd say that people don't do much, which is, you learn a technique, CE grip, Goodell in, bag mask, but you're not assessing that there's rise and fall of the chest and there's fogging of the mask. and you're just going through a system rather than a whole process where you're constantly checking whether it's actually working. Now, one of the things that, and again, one of the traps, and I again hope this saves one of your patients one day, with everything that's going on, the connection tubing to the flow meter often falls off. So if you ever hear, the way you know that is you'll hear the sound of air flowing. If the connection is perfectly on, you'll only hear the gas at the at the bag mask. As soon as you get a bit of a leak there, you'll hear this hissing sound. So it'll be very noisy, it'll be hard to hear, but constantly check that you're actually delivering oxygen. It's so important because you wouldn't believe how many times I've seen the oxygen fall. Now, there's one other thing I want to let you know, which is that with your bag mask devices, they've got a blow-off valve, and that blow-off valve is at a very low pressure. You should just plug that with a little white plug that comes along with it. It allows you to ventilate at 60 centimeters water and not just 15 or 20 centimeters water. I've got a whole bag mask video that's on YouTube, and I think I explain the mechanics of the bag mask ventilator as well. And then, yeah, once our experts arrive, LMA and intubator, hopefully everything is good from there. So CPR ratio 30 to 2. One of the subtleties is the coordination of it. When you're doing chest compressions, you're so tired doing it, you want someone else to be counting. You don't want to count to 30. You want the airway person to count, and you just say, hey, do you mind counting the last 5, 25, 26, 27, 28, 29, 30, and then you know to get them to ventilate and or change rescuer. As soon as you have an LMA or intubate the patient, instead of 30 to 2, it's just continuous 8 breaths per minute. So again, that's the easy answer for that. Pretty much you're getting oxygenation in. You don't really need to wait because you can generate enough pressure even with the chest compressions to ventilate this patient. So IV access and adrenaline. And again, when I'm running the arrests, I really don't need memory for this. I know you'll be tested for your memory. I want you to be able to have a flow chart just on your phones and be able to look it up and go, yep, okay, I need to give adrenaline immediately for a pulseless electrical activity or non-shockable rhythm, and then after the second shock. Now, it gets really confusing if you've got initially a shockable rhythm and then you've got sinus tachy but pulseless, and then you go back to shockable. Just know that it only counts for the first dose of adrenaline, and then you just give it every 2 cycles or every 4 minutes. I hope that makes sense. You only have to worry about the first dose of adrenaline and whether it's shockable or non-shockable. After that, you don't have to worry. Now, you give a milligram, and often this, another quick tip, if you're ever asked about what dose of something to give, there's only a few drugs where the answer is not the whole vial. So 1 milligram is almost always the dose in a small 1 in 1,000 1 mil vial or a 10 mil 1 in 10,000 vial. Now, again, what you don't see happening a lot is the fact that you might give that adrenaline, and if you don't flush it with a whole 20 mils minimum saline, it doesn't go back to the heart because you've got a cardiac arrested patient. That beautiful amount of adrenaline is just sitting in the vein, just hanging out there, doing absolutely nothing. So whether it's in real life or in your exams, make sure you mention 20 mils flush at least.
Sir Lahiru, could you
please
repeat the shockable and non-shockable adrenaline protocol again?
Yeah, absolutely. In fact, I might, so shockable. So let's say you get a shockable rhythm and you go, yep, shock, we shock the patient, do compressions again. 2 minutes later, you go for a rhythm check again. And again, you find a shockable rhythm. Only then do you give adrenaline. So you get your shock and you give adrenaline, and then you go back to chest compressions. Compare that to patient arrest. Everyone comes in, you start doing your ALS, doing chest compressions, you put the Defib pads on, you do a rhythm check, and then you say, oh, okay, that's sinus rhythm. Then you cancel the charge in the Defib, and then you check for a pulse. If there isn't a pulse, that means you've still got a cardiac arrest, and it's a non-shockable rhythm, so I give adrenaline straight away then. And then you go straight back to chest compressions. And yeah, definitely when we're running these scenarios in real life and in our ALS courses, what's interesting is it just gets confusing after if there's different cycles. Amiodarone gets interesting as well. So amiodarone, 300 milligrams, then 15 milligrams over 24 hours. How fast do you do? So you give a push straight up in an arrested patient. You can't do any harm, but just remember, in a deteriorating patient, with some kind of rapid AF or pulsatile VT, you definitely don't give it amiodarone straight away. If you give it in as a push over a minute, patient will arrest, or could potentially arrest right there. So over 30 minutes for a deteriorating patient, but you can just give it for a arrested patient. And now this is interesting because after the third shock, so imagine you could have shockable rhythm, non-shockable, 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 shockable, non-shockable, it could be 15 cycles before you get your third shock, therefore you give amiodarone. A lot of this isn't that evidence-based. So, this is just what the guidelines say. And at your level, this is what you have to know. You may see different practices happening because there might be other information that people know about. So, that's interesting, right? There's only 2 medications. It's probably one of those things that you'll get asked as a multi-choice. There's only 2 medications in advanced life support, amiodarone and adrenaline. And even then, adrenaline is only minimally evidence-based. This is the big trial that happened. So Paramedic 2 trial in the New England Journal of Medicine. Essentially you did have some better survival at 30 days, but no difference in survival to hospital discharge and more severe neurological impairment. Now, this is out of hospital cardiac arrest. So when I think about the anesthetic context, I don't even worry about this. Adrenaline in the right circumstance in my world, where things are very immediate and you might be observing anaphylaxis happening right there or poor contractility happening right there, I'll give adrenaline in modified doses. But this is just interesting for you to know that once the patient is arrested in an out-of-hospital context, it's so much harder to get them back. There's only a few really good things which we'll come to. So, yeah, amiodarone increased survival to hospital admission in shock refractory VF, and really no other evidence. But just remember, if your patient has a heart block which then deteriorates into something, I would still give atropine. There's just, if that deteriorates into PEA, I'd still do things based on the logic that I have for that particular patient. You'll be asked questions in ALS and then questions in deteriorating patient circumstances, and the answer will be slightly different. If you have a bradyarrhythmia, for example, you do want to give atropine. If you have bradyarrhythmia, you might give isoprenaline as well. If you've got hypokalemia, you'll give calcium carbonate or gluconate. So in the deteriorating patient setting and in very specific ALS cause of arrest, you would definitely give other drugs. So successful defib. So there's a third part of the whole thing. So this is one of those things that will happen. People will argue about all the time. When do you do the rhythm check and defibrillate? Pretty much, it's as soon as the pads come on. The reason people discussed it was, let's say someone's arrested and is down. That means their heart and the cardiovascular system are stagnant. And so if you defib that heart with no fresh oxygenated blood, it's probably not going to do any better than what it was doing before. So what they're saying is that you should, get the CPR going, get the blood pumping around, then defib, so you've got your best chance at the first defib. Now, most of the time in real life, this is why, once you know that information, you can judge based on what you've seen. Once the defib arrives, in most circumstances, you've already done a bit of CPR, so the patient's probably ready to go. That said, if you had a patient and the defib was right there, you'd probably just, as soon as the patient arrested, you defibrillate. That happens quite, not often, but when I see it happening, it's in the cath lab or in a CCU. People are there with pulsatile VT, just sitting there waiting for the amiodarone to work with a good blood pressure. The pads are on just in case, and they're just monitoring them. If you ever want a real, trippy ward round, just go to a coronary care unit because they've got everything that's weird and crazy there. So as soon as the pad's on, and then every 2 minutes. But again, if the patient was down for a bit and everyone arrived at the same time, maybe you would take a minute or so for the circulation to get back with chest compressions, then put the pads on. But mostly chest compressions happen before the pads arrive. So anterior lateral, again, just being able to say it's just under the right clavicle and at the apex, that's your anterior lateral, and then anterior posterior. This is felt to be best for DC reversions, which we'll go to in another talk. Is just across the heart on the left side, lower border of the sternum, and then medial of the scapula, again on the left side of the back. The dose is 200 joules, and biphasic waveforms, which are most of the modern defibrillators, is better than monophasic. and they've done some studies for that as well. What you might be faced with, interestingly, is a pacemaker or an ICD, or implantable cardiac defibrillator. If that happens, you need to keep these pads about 10 centimeters away. Otherwise, they could interfere with this already existing cardiac device that's very important for the patient. Now, most of these pacemakers are on the left side of the chest, so this pad placement is pretty good. Occasionally, that pacemaker will be here, in which case I'll go for the AP position. Again, I can just imagine you being grilled about this or a multi-choice question. But yeah, if you've got this side placement of a pacemaker, AP position probably works. And I've got to say, you know, if there's all these other weird and wonderful things on the patient's anatomy, the pad placement, I just look at where the heart should be, and I just make sure that I've got current, the pads are kind of sandwiching this and go across. And finally, you want to minimize the interruptions. Like, it should happen so smoothly, this rhythm check, and I'll show you what that sounds like. Now, what rhythms do you shock? So obviously it's VT and VF, and these will be pretty easy to identify. Now, just know that I used to get really confused between VT and VF. Like, I didn't see it that often, but as long as it looks a bit unusual but regular enough, that equals VT. Okay, so this one is VT. I'd encourage you, I'll give you a bit of time. I encourage everyone to just write down an answer. I won't pick on anyone. What do you reckon this one is? Everyone take a moment to think. Yeah, so that's chaotic. It's not as organized as VT, so that's VF. Now, what's this rhythm?
That's either normal sinus rhythm or PEA in this circumstance.
That's exactly the right answer. So if everyone got that, you know, in the context of ALS, it's either sinus rhythm or you check for a pulse, and if there's no pulse, it's PEA. This one here, take a moment. It's kind of the obvious one. It's asystole. Now, the one thing that used to happen was, just remember that asystole is rarely just a flat line. Just remember, with asystole, you should always check that your lead selection is okay. So you can, there's usually a button that you can toggle between the pads to lead 1, lead 2, lead 3. So sometimes if your pads are in the isoelectric vector of where the heart's conduction is, it'll look like it's asystole. So I just change the pads, change the location of the EC, or where I'm looking at the waveform, just to make sure. If there's a disconnection, in the old days, you just get a line that looked very much like asystole, but now you get a dotted line. So disconnections are rarely a reason to get a flat line looking thing like that. Yep, so that's asystole. And again, all of these rhythms, now this is the way I'd often trick, this is the way we used to trick people with instructor sessions, where we get them back to some weird and wonderful rhythm like SVT or third degree heart block. But just know, again, just like sinus rhythm or sinus tachy or whatever it is, it's PEA if there's no pulse. So a lot of these will end up being PEA, and you just got to check for that pulse. When you get whatever rhythm you get, so you perform a rhythm check and you discover that this is sinus tachy, what's the very next thing you do? So just think about that. You're in the situation, you're there, patient's arrested, you're doing the rhythm check, and so you do your safe coached rhythm check mnemonic, which I'll show you in a second. What's the very next thing you do? So just have a think about that. So yeah, you cancel the charge. So again, in our courses and in real life, you fail if you touch the patient with a live defib. So just make sure you cancel the charge, and the very next step is to check the pulse after that. If there's no pulse, you go straight back, obviously, to chest compressions. Now, if you perform a rhythm check showing VF or VT, you shock the patient, that makes sense. And what's next? So what's the very next action? Again, a common multi-choice question. After you shock VF or VT, what's the very next action? And so, yeah, you immediately go back to chest compressions. You don't wait to see what the rhythm is. Even if the patient got back to sinus rhythm, you still need to keep the heart perfusing, because sinus rhythm straight away can be, it can be poorly contractile. That said, if your patient has signs of life, then it will be okay. You obviously you would stop if the patient has signs of life. So what actually does make a difference? Now, I hope you guys all heard of number needed to treat, but number needed to treat is the number of people that can have an intervention for one benefit or survival. So bystander CPR, number needed to treat 15. Early defib, number needed to treat 5. Adrenaline, the number needed to treat is 112. So it's really, really important that these evidence-based things are done, and we don't think of adrenaline as the be-all and end-all.
Sorry, one question.
Yeah.
When you say early defib, how early?
As early as possible. You get the pads on there, and if you see a shockable rhythm and you shock it, you will be doing so much good for the patient if you do that.
Okay, cool.
Beautiful. Thanks so
I
much.
have a question as well.
Yeah, go for it.
So since we have to keep on doing CPR as much as possible, at what point would you stop doing CPR if you're putting on a defib? Like, is it when you take the rhythm or?
No, so if you, that's a really good question. When someone's doing chest compressions, the person doing the defib pads just gets in the, like, they just work around the person doing chest compressions. On the off chance that, so you do anterolateral, you can do that without stopping chest compressions. But if you're doing chest compressions and you're in the way of an AP position, you just momentarily hands off, put one pad on, keep going, and then roll the patient or lift them up and put one on the back, if that's what you need to do. So yeah, whatever you do, just get those pads on whilst trying to minimize any kind of interruptions. And again, you'll see this done with varying competence. And that's just one of those things that people don't get practice at this, doing this time and time again. And so, yeah, like the likelihood of getting a really fantastic team come together randomly on one of these, in one of these instances is unlikely. So if you were to go to ICU or emergency or theater, you'd probably see really good CPR and stuff happening there because the teams already know each other. Yeah, you do shock torsades in a cardiac arrest patient, absolutely. And just the answer to Brian's question was, yeah, in a PEDS patient, you can put anterolateral or AP position. Yeah, sorry, someone was about to ask.
Oh, yeah, sorry. So when you're about to take the rhythm with the defibrillator, do we stop to let the defib analyze it, or do we keep going?
Absolutely. You cannot analyze with chest compressions going. And actually that comes to our next point. By the way, really, really appreciate these questions, because I remember I had so many questions when I was learning this to start with. And I hope I can get, anything, even whatever you think might be a stupid question, it's really worthwhile, because I guarantee you I've definitely asked those questions in the past. So these days we talk about safe defib, and coached is the mnemonic that we use at my hospital. So it just works well, continue. So literally what happens is phase 2 was getting all the people sorted out. Someone's on chest compression, someone's on defib, someone's on airway, someone's on drugs and IV access. And then the leader might say, now defib person, we're ready for a rhythm check. Can you do the coach mnemonic? And so the defib person will literally say, continue compressions, oxygen away, because you don't want oxygen near where you might be putting electricity. All else clear. So imagine now everyone's just stepped away, including the airway person, but the chest compressor is still going because you want to have minimal interruptions. You then charge, which still feels a bit weird, right? You're charging and putting a live defib while someone is doing chest compressions and touching patient. But, that's why we drill this, to keep it safe. At that point, when the charge is ready, it has a high-pitched noise that's going, it tends to go, and hits a peak. And then the defib person or the leader says, hands off. Chest compressor stands back and says, I'm safe. And then, because there's now no interference, you can see what the rhythm is. And so at that point, the leader usually evaluates the rhythm and they say, yep, that's a shockable rhythm, shock. They shock and then go straight back with compressions. If it's a non-shockable rhythm, we say cancel the charge. They cancel, check the pulse. If there's no pulse, straight back on with chest compressions.
Okay, can you please do another rhythm check, Sophie, and be ready to recommence CPR afterwards, Gareth, if need be.
Okay, so compressions continue. All else stand clear. Oxygen away. I'm charging. 200 joules. Okay, top, middle, and bottom. Okay, hands up.
I'm set.
So can you please disarm? It's a non-shockable rhythm. Gareth, can you please check a pulse?
After 2 minutes, we literally do that again. We're ready for a rhythm check. Defib operator, happy to do coached algorithm. Great. Computer compressions, oxygen away, all else clear. Charging to 200 joules. Wait for a couple of seconds. Charge, hands off to the compressor. They say, I'm safe. We'll evaluate the rhythm now. Okay, shockable rhythm. Please shock. And then go back to chest compressions once the shock is done. You'll see in that video, I'll put the link up at the end of the lecture. in that video, it will show how that's done pretty effectively, and you'll see, the actual demonstration. I can teach this day in, day out, but I really encourage you to watch that video and then just try to go to as many code blues as you can. You want to get lots and lots of hands-on experience. So my actions and aims of that: read out the flow chart, keep everyone safe, and then just show that I'm familiar with safe defib. So, again, for your purposes in the exams or in your vivas, just know that you've got this system that's safe, and that way you can, easily, you get that mark straight away. So phase 4, reversible causes. So now this is one of the things that, you'll ask even experts at this, and you'll ask them the 4H's and 4T's. And it's so hard when a mnemonic has like 5 P's or 6 S's or whatever it is. It's so hard to remember each of them. So I hate this mnemonic a little bit, but if you say it enough, you'll remember it. Hypoxemia, hypovolemia, hypo and hyperkalemia and other electrolytes and glucose all bundled together, so all blood stuff. Hypothermia, thromboembolism is cardiac, so AMI is ischemia, or pulmonary, and there's tamponade, toxins, tension, pneumothorax. So the way this gets around the fact that there's so many ways someone can arrest. Toxins accounts for a whole bunch of things, including anaphylaxis. There's so many ways that someone can die, but say someone's got pneumonia, that ends up going to sepsis, which becomes relative hypovolemia. So this is just a way you can tackle a lot of common bad things, but it's not the be all and end all, okay? But it's a really good framework. And I use this constantly as a resident. I'm on a night shift. I just want to show that I'm being thorough. To my mind, I just want to make sure I'm being really thorough when I'm assessing a sick patient. So if the patient's sick, I do my normal assessment, and then I just write the 4H's and 4T's to make sure that I'm really just looking at all the bad things that could possibly cause a deterioration here. So my actions are literally, I verbalize each of these possible causes. Again, whether I'm the leader of resus or if I'm in an exam, I want to verbalize these things, outline each of the aspects of history, examination, investigation that support the diagnosis, and then talk about what further investigations or assessment you need. I don't think it's a pneumothorax, or maybe they've had some bullous lung disease from COPD. It could be a pneumothorax. So I'd want to check for the trachea, auscultate the lungs, and get a chest X-ray, and then decompress if I'm ever concerned there's tension. That's the kind of language I use. I then mention the likelihood of each as I go through. And I'll give you an example of that in a second. And then I start treatment, supportive care as I'm going through. As the leader of a situation, you can often offload these things to various people. So if I'm thinking of tension, I'll say, hey, can you auscultate the lungs, check the trachea, and if you're worried, let me know, and we'll get a chest X-ray and maybe needle decompress while I'm looking at some bloods for hyperkalemia. You can offload each of these really effectively. Now, so my aims in this phase 4, phase 1 and 2, I'm just keeping the organs viable, just keeping the heart going round, so the blood going round and round, and oxygen going in and out. And now phase 4, reversible causes, to solve the problem to restart the heart or the circulation. So if I give you this example of a very unlucky patient, so you've got a 7-year-old, day 3 post-op total hip replacement. They got everything, imagine, for the purpose of this. They've got ischemic heart disease, end-stage renal failure, it's secondary to diabetes, and they've got severe COPD, and they were just given antibiotics and found unresponsive with a large swollen operative leg. Great, so this is the Olympics of unluckiness. Now, the resus team is doing great CPR, and then you help the team go through the reversible causes. So using a focused history examination investigation framework, I could talk through each cause. So hypoxemia, so this patient has a history of COPD. I would check the vitals to make sure that the saturations weren't suddenly decreasing in a really bad fashion. We are giving 100% oxygen, and we're looking for adequate ventilation with that. So I've sorted out the oxygenation. We're doing the best we can. This patient could be hypovolemic. They've just had an operation. They've got a swollen leg. So I'd look at the obstruction, I'd look at the drains, I'd check the HB, and I'd give fluid if I thought that was the cause. This is literally how I talk through it. I think about what it is, think about the situation, and what I need to do. Hyperkalemia, yeah, this is likely. It's end-stage renal failure and diabetes. I'd send an urgent venous gas. I'd check the old bloods, and then I'd prepare all the hyperkalemia things as well. So, calcium carbonate, sodium bicarb, whatever else you need to decrease your potassium. And if it was blood sugar, I'd get that reading straight away and give glucose. I'd mentioned that hypo or hypothermia is unlikely in hospital, but I could check a temperature. So tension pneumothorax, this is severe COPD, and this could have occurred due to bullous emphysema. So I'd listen to the chest, check tracheal deviation and needle decompression if necessary. Thrombosis, this is an elderly patient. It is concerning for ischemic heart disease. I'd check previous rhythms, check the ECG, and then make an assessment. If it's pulmonary, again, it's likely with the operation. I'd check for TEDS and Clexane that is given, and the swollen leg I'd examine and check for signs of a DVT, and then institute management as necessary. Tamponade is unlikely in this picture. It's usually post-CAGs or trauma. And then toxins, I'd check the med chart, and they've been given antibiotics, so it may be anaphylaxis, so I'd look for signs of that. And I'd check also for local anesthesia infusions that could have happened. So as you can see, I'm really just going through and talking about each of those from a history, examination, investigation point, and I'm also giving information as to what I think is most likely. So the big insider tip I'd have is, even though you're med students, you will have some kind of clinical acumen for what is likely to be going wrong. So in real life and in your ALS assessments, consider the patient's context to prioritize the most likely differentials. So 50-year-old with end-stage renal failure, for example, will be a particular thing. Now, actually, I'll get you guys to just write down somewhere what you think is most likely. 80-year-old fractured NOF, 20-year-old with an infected leg just given antibiotics, a 30-year-old with chest trauma, a 40-year-old with diabetic pneumonia. So just take a second and just write those down that you think is most likely, because that's the way you want to address this. End-stage renal failure, hypokalemia is a typical thing there. Fractured NOF, thrombus, it could be PE or an AMI. Given antibiotics, it could be anaphylaxis. Chest trauma could be anything to do with trauma. It could be blood loss, it could be tension pneumothorax, tamponade, it could be hypoxemia as well. Diabetic with pneumonia, it could be hypoglycemia, maybe they gave too much insulin, maybe it's hypoxemia, maybe it's sepsis. So again, the insider tip for how you sound better in the exams you might do, but also in real life when you're trying to find exactly what's going on, you prioritize the most likely differentials. And this is literally how we construct our situations. Again, I wish someone told me this earlier. By the time I went and do my ALS instructor course, this was so obvious to me that each situation felt pretty easy because it wasn't a surprise. Like once you know how the examiners are thinking, this is how it is. So the last phase is really just post-resus care. Again, really important because once you've got the patient back, again, I've seen this so many times where people breathe a sigh of relief without nearly the level of intensity that you should have for an arrested patient. But it's almost like, oh, good, patient's alive. Whew. But just think about it. If I was in theater and the patient's blood pressure dropped to 60, I would get an art line in, I'd be giving fluid, giving adrenaline, I'd be bumping that blood pressure up to 100 systolic minimum just to make sure that I was perfusing organs. Now, the thing is with an arrest, you haven't put all the monitoring on. So you need to do so many things to make sure that you've got the patient back and now you want to keep them from deteriorating again. So I'd reassess and optimize my ABCDs constantly is the first thing. And that means getting all your monitors on, making sure you've got an artery infusion running, getting the blood pressure to an appropriate level, and just constantly assessing your blood pressure and oxygenation and everything else. I then go a whole gamut of investigations, ECG, echo, chest x-ray, bloods, and maybe more specialized things, angio and CTPA, for example. You'd keep going with specific treatments. So, whatever the reversible cause is, you'd have to keep doing that. Maybe it's cath lab, maybe it's targeted temperature management, maybe it's thrombolysis for PE. And then finally, disposition. Wherever you are, the patient who's arrested is very rarely going to be ideally managed where they're arrested. So if it's on the ward, they'll be taken to ICU or theater. If it's in theater, they'll be transferred somewhere else. If you're in a small hospital, you go to a big hospital. So I want you to think about these 4 stages of the post-resus care. They don't outline this in a lot of detail in the ALS flowcharts, but this is, I find, a really logical and really good way of just going through that. And again, my aims, I'm just trying to keep them stable, prevent further deterioration, definitive ongoing treatment, and then transfer to appropriate location. So, the summary is these are the 5 phases. The flowcharts are, to me, not conducive for me to understand exactly what's happening at each step. So that's why I've done the 5 phases, which identify the rest: CPR cycle, safe defib, reversible cause, and post-resus care. And really, again, my aim is just keeping the patient alive until help arrives, organizing roles, which is all those multiple roles that need to be absolutely done, and then diagnosing and treating the causes with the reversible causes, and finally transferring for best care.
With the pulse checks that we talked about earlier and a non-shockable rhythm, can I confirm, so shockable, you're not bothering to check the pulse, you're just getting going with
absolutely
everything that we've just spoken about. With your non-shockable though, so you've evaluated the rhythm, you've determined it's non-shockable. At the same time, just before you're starting compressions again, you're doing a very quick pulse check.
Yep.
Is that correct?
That's exactly correct. And it seems a bit odd because on one hand, we say, don't pulse check, just go straight for chest compressions. And then in the next breath, we're saying, oh, actually, now you need to pulse check. So there's a few little contradictions in this, and that's okay, because once you get used to this and once you get senior, you'll be able to move in the gray areas. Right now, you don't need to know the gray areas as it happens, but you will very soon be required to play in those gray areas. So that's a really good question. So, I mean, for example, there is a thing called pulsatile VT, but we're saying that don't check the pulse, just go straight in. But I know that if you've got a patient who's constantly going into VT in the cath lab or in CCU, I have no doubt that they've already got an outline in, and you're looking at the pulsatility, and you're not just starting chest compressions. There's all these gray areas, and that's a really good question. Just know that, but just accept that this is the thing that you'll be learning and doing, and then you'll make the modifications with seniority.
Perfect, thank you. The other question that I had was in regards to the defibrillators themselves. Can I confirm that in most of these scenarios, like every scenario that I've been in, it's always been a defibrillator where I don't have to adjust voltage or anything unless it's a pediatric situation. But I was just wondering if you can talk me through that, because I think I've only pediatric.
So you can either use 150. So biphasic, you can either use 150 or 200. It's such a big amount of joules, it doesn't really matter too much. And some guidelines say one or the other, hospital guidelines are different. So just go 200. It's the easiest thing to do. For pediatrics, yeah, you definitely have to change it. It's 4 joules per kilo. And I can do a session on pediatric and other special circumstances later. But essentially pediatrics is exactly the same and really not different at all from ALS, advanced life support, except for the fact that your joules are 4 joules per kilo, and you just do a rough calculation. You won't be able to get it exact. I just go a little bit higher than what I calculated, 4 joules per kilo. And your ratio is 15 compressions to 2 breaths, not 30 to 2. Oh yeah, and the doses are different. Adrenaline is 10 mics per kilo, and amiodarone is 15 milligrams per kilo. But otherwise, the algorithm is exactly the same. Sorry, someone was just saying something.
I was just going to ask, so with the defibrillators themselves, they're already generally like in a resus environment, say in ED, we're on placement there or whatever, they're already preset to their 200, and it takes us to go and change it?
Oh, sorry, they're not preset. There's a dial, and I can probably show you this if I've got it up here. See this dial here? Hopefully that's big enough. You will literally rotate this dial around to 200 and then start. If it's a child and say there's 10 kilos, 10 times 4 equals 40. So I just go to 50, just round up. So yeah, you'll definitely have to do it. AED is an automatic external defibrillator. That just does the defib. That just does everything for you. It just asks you to press a button. It asks you to hands off, and you don't have to select joules in an automatic defibrillator. Actually, a good question here. How long would you give for an internal pacemaker to deliver a shock before you consider it's not firing for whatever reason and you need to give a shock via a defibrillator? That's a really good question. It's actually happened to me where someone had VT that was pulseless, but the VT was just slow enough that the AED didn't shock. So we were waiting there, just twiddling our thumbs, wondering why this poor patient who was about to die on us wasn't getting defibbed intraoperatively. And so I would say don't wait more than 10 seconds. Otherwise, I don't have a good answer for if there's an exact amount of time. If your patient isn't getting shocked and you can't see anything occurring, it could be due to programming issues or some kind of malfunction, because we don't know how this, I'm not an expert in internal defibs. I would shock if I didn't see anything happening. Apart from return of spontaneous circulation, what other factors do we consider for the duration of continuing the cycles in ALS? I've observed varying durations in different. It's such a different. It's such a big discussion about futility in certain patients and also the reversibility of the cause. For example, an elderly NOF from a nursing home with dementia, you may not do much at all. They may have treatment care limitations, whereas a 20-year-old who's had bupivacaine toxicity causing an arrest, bupivacaine just lasts a very long time. You may continue an arrest for 1 to 2 hours because you know that there's a reversible cause and the patient had, good quality of life. So it's such a complex discussion that I'd say you could talk at it in general terms and principles. A lot of people say half an hour of an attempt is probably enough. I'd say what I've noticed happening in most patients who aren't futile is not just half an hour, but probably an hour or so. I think that's just my rough experience. I think if you ask your ICU colleagues, they'll know their experience a lot better. They're far more comfortable and more experienced dealing with death in these circumstances than I would be.
I had 2 questions, if that's okay.
Of course, yeah, go for it.
So are there any circumstances where if you see a patient just fall on the ground and is unresponsive on the ward, would you ever check for like an advanced care directive, or do you just start CPR immediately?
I don't know if there's an advanced care directive straight away. I just start because the implication of me going to search for it is just too serious. It's a really good point. I mean, unless I know it, death is final, but I can always withdraw care. And from your point of view, you're not, if you're worried about negligence, all that kind of stuff, you're acting in good faith that you're a medical practitioner trying to do their best, and no one's going to expect you in that real world situation to be looking for an advanced care directive if it's not known. A lot of times wards will have a whiteboard where they've got the patient, the details and various notes on it. So I would probably have a glance at the information there. And I'm often the outsider coming into the ward. I would immediately ask for the head. If this patient looked like they were the elderly patient and they just looked like they're unwell from the beginning, I would ask, hey, you'd often hear this, is there an advanced care directive? But that happens aside from the fact that you're running this arrest.
Yep, that makes sense. And the other question was, are there any specific circumstances where, we wouldn't transfer to ICU? Because if they've had an arrest, I would think they would need ICU support.
If anyone has had an arrest, almost every single patient I've seen in that circumstance gets transferred to HDU ICU. Yeah, they just need more monitoring because of the likelihood of relapse. I can't even imagine a circumstance where maybe in theater where there's like just such an obvious reason for what happened and it was very short and there's barely any chest compressions, maybe you would not do it in that circumstance. Chest compressions themselves have trauma. You might get rib fractures, you might get cardiac contusion. So there's so many things that could be going on. The very safest thing, and in my experience, what's happened is they go straight to ICU, HDU, or coronary care.
So even with someone with, like, for example, hypoglycemia, and you treat immediately, they would still go ICU?
Oh, look, hypoglycemia that's arrested. Yeah, I think you would, because there was then a downtime and chest compressions that could result in trauma. They may only be there for a very brief period of time, but I can imagine that you'd at least have to have a couple of hours of observation. Often the hypoglycemias don't arrest that I've seen. I've seen some really low sugars and they're just unconscious, but they haven't arrested. So I suspect that that's more of what you'll see. You won't see many arrested hypoglycemics.
Yeah, makes sense. Thanks.